you, everyone. Before I introduce Dr. Bauer, I wanna say some things. I'm gonna change for in Portuguese for the audience. Just a second.
So everyone from the audience, well, actually, when you get in, when you enroll, you have the option for English or Portuguese. And this is live on the main stream on that channel. And then you can ask questions in Portuguese or English as well. These questions are going to be submitted directly to us in either language. And then after the closing of the last presentation, Dr. Bauer's presentation, then we can do, well, actually after Dr. Rafael's, then we're going to do the Q&A with Todd Bauer and Rafael Arregui. So those are the instructions, just so we can start the event. And now I will adequately present our guests.
Well, thank you, Dr. Todd Bauer, for being here with us tonight. We are online, but Dr. Bauer is here in Instituto do Câncer Brasil. It's a pleasure and it's an honor to have you here. Dr. Bauer, it's a medical oncologist and senior investigator at Sarah Cannon Research Institute, Nashville, Tennessee, USA. This is our international meeting, ICB international meeting, and I'm grateful for you, for the audience, and for Pfizer to all have this meeting tonight. Dr. Rafael, it's also here. Rafael Arregui, it's a medical oncologist in Corumbá, one of our cities. It's Central West, it's Middle East Brazil, and he's far away. He's probably closer to Dr. Bauer than I am. So thank you, Rafael, for being here. And let's start. Thank you again, Dr. Bauer.
It's my pleasure. Thank you for that kind introduction. And I greatly appreciate the opportunity to join you guys via Zoom. I'm a little disappointed I couldn't actually make the trip and visit what I believe is a beautiful country based on what I've read and seen about it. But I do appreciate your time, and I look forward to sharing with you tonight my experience with some of these newer ALK inhibitors, specifically probably focusing a little bit on lorlatinib, a drug that I've had the chance to work with since the first in-human dosing. I gave the dose to the second person ever, and have had a patient on this drug for over 7.5 years. So I'm glad to be able to share that experience with you. Seeing this drug go from first in human to FDA approval, sort of like seeing one of my own children grow up and graduate college, which I haven't seen that yet. And don't ever say I said that to my wife, but it's fun for me to have this talk because I believe so much in this drug and how it works. So what we're going to get into is how do we figure out what to use in ALK-positive lung cancer? Because we have a little bit of what I would call an embarrassment of riches. There's so many good options. It's not clear what the best option is. I do want to run through a quick case review of lorlatinib in the first line setting. And then I want to talk to you about some of the side effect management of lorlatinib, because that's been a little bit of a buzz around the drug, is that it's hard to give or not tolerable. But I really want to focus on what that means and how we can better manage those. So when I say embarrassment of riches, what do I mean? Well, the first paper describing EML4 ALK translocation as a oncogenic driver was published on August 7th of 2007. If you look at August 26th of 2011, that was the approval date and accelerated approval for crizotinib in the United States, just 4 years and 2 weeks and 2 days later, which is incredible scientific progress. But over the ensuing decade, we've seen the approval of ceritinib and alectinib and brigatinib, more recently lorlatinib, and now first-line approvals as well for those drugs. We still have ensartinib out there, yet another drug that works well against ALK inhibitors, that's published its first-line data and is just awaiting what we expect to be pretty soon approval by the FDA. Now, how do you sort out which is the best of these drugs to use? Because if I've got 3 drugs that are approved in the first line, how do I know? Well, one might go to the basic science and try and understand the drugs at that level. Now, we know that basic science doesn't always translate out to clinical relevance, but I think this might be a hint into what we do. You know, I typically will say, nowhere in oncology do we save our best drugs for later. I use a lot of sports analogies. I might be so bold as to say, Roberto Carlos doesn't come off the bench. He starts the game, right? We don't save our best players for later. So which is the best drug? Well, we know that not all ALK translocations are the same. We see that there are 8 different variants that we know of now, where that break point and where that fusion point between EML4 and ALK actually occur is different. And we look at that on a pie chart, we see that there are different percentages of those. Far and away, variant 3A and B and variant 1 are the most common, probably accounting for what I would say is about 2/3 to 70% of the EML4 ALK translocations. So if we know that, can we then look and see which drugs work best against those? This is what we call a heat map, or a stop-go chart, because of the red and green. As someone who is red and green colorblind, I call it a cruel joke, but what I can read are the numbers. So if you look over here at EML4 ALK variant 1, in the wild type, no resistance mutations, and you look left to right across that chart, you'll see that number getting smaller as you go across. That number is the IC50, and the lower the IC50, the more potent the drug against that particular item. So in this case, lorlatinib is a 0.267 against EML4 ALK variant 1 versus crizotinib at 23. So that's a dramatic difference. When we look at that ALK variant 3, you see an even more profound difference of 4 versus 205. So it would seem, based on this information, that lorlatinib is the most potent ALK inhibitor that we have experienced against the most common EML4 ALK variants that we see. What does that look like? A little bit slightly different. Well, the IC50 on a bar chart shows you really can't even see it on EML4 or on lorlatinib over here at 0.267. It's infinitesimal. And again, on the variant 3, you see that dramatic difference. So lorlatinib is the most potent drug against the most common ALK fusion variants. So there have been 4 different first-line trials of these 2nd and 3rd generation ALK inhibitors. We group alectinib, brigatinib, and ensartinib as 2nd generation, and lorlatinib is a 3rd generation ALK inhibitor, primarily due to its macrocyclic structure and a little bit of different efficacy and penetration through the brain. These 4 studies were very similar in their construction, about 300 patients in each. They looked at objective response rate as a primary outcome. Now, one difference is the alectinib study, ALEX, used investigator assessment. The other 3 used independent review committee. You see good response rates in all of these versus crizotinib. And crizotinib is not bad with a 60 to 75% response rate. And when you look at those objective responses for lorlatinib, ensartinib, and brigatinib, you're about 75%, and that's the blinded independent review. Alectinib in the investigator opinion was about 83%. Median progression-free survival, which is another primary endpoint, and what these drugs are being approved on, by the way, we see a progression-free survival of 26 months versus 10 months, alectinib versus crizotinib, 24 versus 11 for brigatinib, 26 versus 13 for ensartinib. And then we get down to lorlatinib, and we haven't yet reached that. Now, the CROWN study, the lorlatinib study, is the most immature of the data. But what we can look to there is the hazard ratio, where for the other 3 studies, it's 0.5. That's incredible, a 50% risk of progression in these patients. But the blinded independent review committee for lorlatinib, the hazard ratio measured down to 0.28. If you look at the investigator assessed, it's down to 0.21. So clearly there's a dramatic difference in progression-free survival in patients on lorlatinib versus crizotinib. Now, one of the things that I think is the most common thing we hear, right, at any international medical meeting, when someone's standing up on the podium, what do they say? We aren't supposed to do cross-trial comparison, but, right? So we aren't. You can't do that statistically speaking, and evidence-based medicine says you shouldn't. But in a world where we have 4 first-line trials, I don't think we'll ever see a head-to-head of any of these. We're left with no better data than to try and parse these apart and look at them. So we've seen these PFSs. None of these drugs are bad. All of them are better than crizotinib. So what do we do about that intracranial objective response rate? Because we know for our patients with ALK-positive disease, that's a huge problem. 30 to 40% of these patients will present with intracranial disease. Most of them will develop it within a year if we aren't treating them effectively. So what about that response rate? Well, none of these drugs are bad, right? Alectinib works great in the brain, 81% objective response rate, 78 for brigatinib, 64 for ensartinib, and 82 for lorlatinib. But there is a difference. Now remember, lorlatinib as a third generation drug was designed to better penetrate the blood-brain barrier. So let's look at that CNS complete response rate. Which drugs better took away all those CNS lesions? Well, we see alectinib at 38%, brigatinib at 11%, ensartinib at 27%, but lorlatinib has a 71% complete response rate in the brain. So if we're basing it on the most effective drug preclinically and the most effective drug in the brain, I think we have to look at lorlatinib. Now, this is a great slide that Christine Lovely put together, and I appreciate that she let me borrow it for tonight. She presented it at ESMO year before last, but it shows the progression of this data. And we've talked about the hazard ratios and the objective response rate and the PFS. What I think is important about what she's illustrated here is as you look at alectinib, which is the longest running of these, we see a good maintenance of that separation between alectinib and crizotinib, such that we know that these are lasting benefits as well. Now, I actually think this is a very important slide based on the side effect profiles, because we've established that all of them are effective. All of them work in the brain. Lorlatinib's maybe a bit better in the brain based on a 71% complete response rate. But what about those adverse events that you may have heard so much about for lorlatinib? It's a hard drug, patients don't like it, it's hard to dose. Well, let's look at that based on the evidence, because if we're doing evidence-based medicine, that's all we have. Again, across trials, how do we compare those? Well, treatment-related adverse events leading to dose reduction. 50% of patients on lorlatinib, we had to reduce the dose versus 47% in crizotinib. That seems pretty high, right? Alectinib only 16 versus 21%, brigatinib 28 versus 29, and ensartinib 24 versus 20. So in each of these, the comparator, the newer drug, was about the same as the primary drug, lorlatinib, or crizotinib rather, forgive me. But what we do see is a much higher rate of both of these in the CROWN study. I don't know how to account for that other than this is cross-trial comparison. But what I think is actually more important than how much you have to dose reduce, because we all give chemotherapy, we all know you have to reduce drugs at some point, is how many people did we have to take off of those studies, off of those drugs, because we couldn't manage the side effects. Look at this. Lorlatinib, only 7% of patients had to come off of the drug due to toxicity. Alectinib 11, brigatinib 12, and ensartinib 9. So I'm not saying that's statistically different. All I'm saying is if you look at this data, if you manage the dose of lorlatinib appropriately, patients are able to stay on it at rates consistent with every other ALK inhibitor out there, or the other second generation ALK inhibitors. So a little bit of disconnect from kind of the scuttlebutt, as we say in the States, on which is the harder drug to give. Well, maybe we as the prescriber think it's harder because we have to manage it a little bit more. Yeah, I might have to work harder to get my patient this drug, but is it worth it? And we'll think about that a little bit. So how do I approach which drug is the best one to give in this setting? Well, first and foremost, brain mets come to mind, right? None of these drugs are bad, but we know that lorlatinib seems to be the best in the brain based on that complete response rate. If I see a patient who's presenting with a brain met at presentation, do I want to give them the second best drug out there because then I have the best drug down the road? Or I just want to take care of the problem up front and not have to worry about my next best drug? So brain metastases are the single most defining characteristic about who I decide definitely to give lorlatinib to up front. What if they don't have brain mets? Well, there's a lot more gestalt that goes into that. What is their primary occupation? Do they have a history of other CNS issues or depression or anything? And what is their capacity for acceptance of brain met progression? Because I think what we see is that, and we're going to come to that slide later, I got mixed up in my order. What we see is that lorlatinib is actually quite protective in the brain. So we'll come back to that. But let's look at those PFS hazard ratios when we look at everyone, patients who don't have brain mets and patients who do. So let's go back to this. So I will use alectinib as the comparator just to keep it constant across these different graphs. We see a hazard ratio of 0.28, all comers intention to treat for lorlatinib versus 0.47 for brigatinib. So great drugs both, but a better PFS hazard ratio. When we go to those patients who don't have brain metastases, we see the PFS hazard ratio go up a little bit in lorlatinib and come down a little bit in alectinib. That suggests that in those patients who don't have brain metastases, maybe there's not quite as much of a difference between those two drugs. What about in the patients who do have brain mets? Well, that's where we see that number separate out, and you go from 0.228 to 0.2 hazard ratio and a 0.47 to 0.4. So really, it's in the brain that lorlatinib separates itself out from alectinib. This is the slide I was looking for 3 slides ago. What we see is with lorlatinib, at 12 months, the cumulative incidence of progression is only 2.8%. Compare that to the old standard crizotinib, where you had a 10-fold increase, a 33.2% incidence of brain mets within 12 months. So the hazard ratio for CNS progression without previous non-CNS progression is 0.06. I don't know that I've ever seen a hazard ratio that looks quite that small. Essentially, lorlatinib is very effective at protecting your patient's brain from progression. Now, this is another slide that I've stolen from Ignatius, where you see a little bit of creative thinking about if we can figure out what that PFS will be based on the hazard ratio and the crizotinib comparator. We see that in the CROWN study, that PFS looks like it might be the longest at 33 months versus 26 in alectinib. Again, this is a little bit theoretical. This is not published data. But what about if we look at the investigator assessed? Now remember, investigator assessment of alectinib was that it was better than the blinded independent review committee. That's going to be true across the board, we assume, for all studies. But when you look at lorlatinib, based on that 0.21% hazard ratio, the projected median PFS is 43 months, so nearly 4.5 years, which is pretty incredible. So having gone through that data, what I'd like to do now is run through a case with you. And this is a healthy 58-year-old who presented just last August, or a year ago now, and had a 3-centimeter right upper lobe lesion. They went for resection, cure of intent resection, but they found positive level 7 and 8 nodes, giving them a staging of stage 3 non-small cell lung cancer. They were out positive on liquid and tissue testing. They decided to move forward with a treatment for cure with concurrent chemoradiation with carboplatin and Taxol, and this was completed September through November of last year. Unfortunately, those first restaging scans did demonstrate 2 CNS lesions, the most predominant of which was demonstrated here in the right posterior lobe. So this patient was started on lorlatinib December 8th, 2020. They had good tolerance with no CNS side effects, but look at what happened to their cholesterol. We went from a level of about 270 to a level of about 350, sorry. And the triglycerides similarly catapulted way up. We're going to come back to that because that's the single most common side effect profile we see is progression or elevation of the lipids and triglycerides. This patient had restaging scans about 2 months later on February 2nd this year. And what we saw was a complete resolution of the CNS lesions as evidenced by this image on the right. So good CNS penetration. Now, again, this patient did not receive CNS radiation. They only received lorlatinib and we saw a complete response. However, lorlatinib is a different drug and there are some different side effects to it. I mentioned the most common thing we see are hypercholesterolemia and hypertriglyceridemia. I'm going to ask for a show of hands, and in my mind, everybody is going to raise their hand to this question. You've all used immune checkpoint inhibitors, and you've all seen the development of autoimmune hypothyroidism. I don't think any of us stop those therapies to treat that, right? We continue treatment with the immune checkpoint inhibitor, and we concurrently start them on Synthroid and watch their thyroid levels get better. This is the same way of management for the cholesterol. We don't stop the treatment. You start a statin, and the choice of statin is actually important based on CYP interactions. And we treat them through that and watch the cholesterol come down. The other most common side effects we saw were edema and peripheral neuropathy. Then you start to get into those cognitive effects, mood effects, and even some weight increase. So how do we manage this? Well, if those are mild, you can either try and treat through it or hold the dose, let it resolve, and re-challenge at the same dose. If they become moderate or severe, you should hold lorlatinib until the side effects resolve, and then probably re-challenge at one dose level lower to make sure that they tolerate it. If it's a grade 4 toxicity, the recommendation is probably to permanently discontinue lorlatinib. Now, we're shifting a little bit here. I'll make that clear. This is not the CROWN data I'm speaking of now. This is the phase 1 and then the phase 2/3 data, that temporary dose interruptions and dose reductions were reported in 22 and 20% of patients. So a little bit lower than in that first line data. The most common cause for these was edema. And the incidence of permanent discontinuation was only 2% in this population. So more heavily pretreated, maybe a little bit more accepting of those side effects. And the reasons that these were discontinued were cognitive disorder and mood disorder, as well as edema and fatigue. So this is a wonderful slide that Ignatius did a great job of laying out where we see these develop. There have been reports of acute psychotic issues. I've not seen them personally, but I believe the reports when I read them. These were auditory and visual hallucinations, as well as one olfactory hallucination, which I don't think I've ever heard about actuality except for in psychiatry class as a medical student. These do resolve with holding the drug. None of these side effects are permanent that we've seen in any of the clinical data so far. Later on, as patients have been on the drug a bit more, we do start to see an increased appetite or slowed speech. And I often get a question about, what does the slowed speech look like? Is it word finding difficulty? Is it stuttering speech? It's not. It is more of if you took an old 45 LP and put it on the turntable and played it at half speed, the words just come out more slowly, and it's just a more protracted pronunciation of the words. But most people tolerate that fairly well. Now, we show here that we see the hypercholesterolemia and hyperlipidemia occurring in the 2nd or 3rd month. I actually start checking that at the 2nd week, at the 4th week, and then monthly thereafter, because I do expect to see it fairly quickly. This is a pretty busy slide, and I apologize for that. But the reason I pull this up here is to remind me to share with you something I think that's incredibly important. There's no way that you, as a treating physician, seeing a patient for 15 to 20 minutes every 2 to 4 weeks is going to be able to pick up on small cognitive changes or small increases in depression or even euphoria. It's really important that you get your patients, caregivers, and loved ones involved in the care to make sure they are aware that, hey, this can cause some changes in their thinking. They might have some slowed thinking. They might be more depressed. Watch out for those and help me know if we're seeing that, because patients won't often want to admit those things, right? They want to come in and put on a brave face and say, everything's great, life is wonderful, this drug is wonderful. And that's true on chemotherapy, so you know it's going to be true on an oral agent also. So the CNS effects that we see, and this is probably the biggest, most widely reported, or widely discussed thing out there, though it's not the most common. We saw changes in cognitive function, mood, and speech. These were seen at 40% in the phase 2/3 study, with 12% experiencing more than one of them. Now, here's the thing that I think is a little bit confounding on this, and this is Todd Bauer opinion purely. This is not published data. Remember, in these early studies, we had patients who'd been heavily pretreated, up to 4 prior ALK inhibitors and chemotherapy and whole brain radiation. And 72% of them that reported CNS side effects did have CNS lesions that had been previously treated. So as you look at this, you have to wonder, what does whole brain radiotherapy really look like 5 years down the road? And please don't hear me. These are real side effects. We need to watch for them. I just think that the concern or the angst about these side effects got a little bit adjusted early on in the course of this drug. 24 patients out of the 117 in this data set did require dose reduction. 15 did experience resolution. The median time to resolution was 12.5 days. I'll tell you that the most significant side effect I've seen with lorlatinib is my patient who's been on it the longest amount of time, 7.5 years. He was at the recommended dose of 100 milligrams daily. We eventually had to reduce him to 75 milligrams daily. And after being on that for a couple of years, he then developed seizures spontaneously. Now, he'd had CNS lesions in the past. He'd had whole brain radiotherapy in 2014, and was terrified that he had progression of his disease. I was able to show that there was nothing changing in the brain. We held his lorlatinib, and about 8 days after holding it, everything resolved and he was back to normal. We did go ahead and lower his dose to 50 milligrams. He had no recurrence of those side effects, and he has been maintained on that dose for going on 3 years now. So even at a lower dose, which we sometimes have to do, dose reduce to make the patient tolerate, it is still a very effective drug. Now here's a Venn diagram of those side effects. Most people did experience just one of them, but a small number will experience multiple of them, most commonly mood and cognition combined together. The therapy management we've touched on, if it's mild, you can try and press through it or hold it and re-challenge, or you can start to dose reduce after holding and they resolve to 0. This is really important data and speaks to what we've just been talking about. Ben Solomon, who he and Alice Shaw and I go back to that phase, that first in human dosing. He presented at ESMO this fall, outcomes for CNS adverse events. So what we see on here is that of the total number of CNS adverse events, 86 patients had them. 53% received no intervention, and still 28 of those patients, or 33%, had resolution. There were different interventions. One of them was ConMed. So we instituted rosuvastatin for the hypercholesterolemia, or instituted Lexapro for depression, right? So these are CNS side effects. Then we saw those patients who had dose modification and or addition of medicines. And each of these go down through dose reduction, dose introduction, reduction and introduction, all the different iterations of how you could possibly manage these. And what we see when we look at it, the vast majority of those patients had full resolution of their symptoms, 56% with total resolution, 3% more with resolution, and 38% who weren't fully resolved, but back down to a lower level. None of those, I will mention, resulted in a treatment discontinuation. So this is a manageable drug, and that's really important. I think we've talked about this pretty extensively, but hyperlipidemia is the main thing that we see with this. You need to manage their lipids prior to starting, and you do need to watch those closely because we do see escalations. If you don't treat this, the cholesterol will just keep going until you get scared and you do treat it. Even at a cholesterol of 500, I still don't hold lorlatinib. I continue it, and I add in rosuvastatin is typically my choice, but pitavastatin and pravastatin can also be used. Older statins interact more with CYP450, and so they can actually exacerbate the side effects of lorlatinib. So you want to be real careful with which of those you choose. There are 2 more recently described events based on EU data, where we saw hypertension and hyperglycemia, 13% and 9.2% respectively. The management of this is the same, guys. I hope that you've gotten through this at this point, that it is essentially, if it's low grade, you continue and see if it continues. You optimize medical management. If you can't manage it that way, you hold and dose reduce. And if you can't get them through with dose reduction and optimal medical management, you may unfortunately have to discontinue lorlatinib. So guys, that is my slide talk. I apologize. I think I ran over, but I hope you found it useful and look forward to discussion going forward.
I do have a lot of questions, but first, I think I would like to invite Dr. Rafael to present his case, and then we'll discuss. Thank you.
Thank you.
Good evening, everyone. Well, it is a great pleasure and an honor to be here with all of you, very renowned oncologists here in Brazil. And well, the presentation for today is of a clinical case. Real world data with the difficulties of real world that we're going to see. We're going to see a few specificities here. So my disclosures. Okay, so we can start. Patient, male, 41. He's a fisherman and Catholic. He has a long-standing, undefined, and a progressive worsening pleuritic pain with some febrile episodes and without respiratory symptoms. History: anamnesis, obese, no other comorbidities or regular medications. He was a smoker, 25 packs a year, regardless of the age. He was a social drinker. Family history: the mother had breast cancer at 66, and she's also my patient. So we did a CAT scan, torics, at the end of December, beginning of 19, and we have multiple nodes, pleural surface and diffuse, pleural thickening, as you can see on the slide, and pulmonary nodules on the left, and largest nodule is on the lobe, 2.3 centimeters, and a micronodule. The initial biopsy has the carcinoma with an acinar pattern, cibriform, and with papillary outlines. The patient was my patient at the time. He only became a patient when we started the treatment. Thereafter, after this biopsy with the sampling, we did the segmentectomy to evaluate. We did this left pulmonary, and the biopsy showed the carcinoma with the same cibriform pattern, lesion 1.5 centimeters, resected with the invasion of the pleura and the pulmonary metastases. So we did the PET scan at the time. Besides the multiple pulmonary nodules, about 3.1 centimeters, we have a diffuse commitment of the intestinal costal pleura and also the rectal inflammation, and he had an abscess. He did the upper digestive endoscopy. The brain MRI is normal, and he did the colonoscopy, and well, he had a little bit of a pyrosis. The primary tumor, well, the endoscopic results were normal. So immunohistochemistry, just to talk about the little difficulties on this case. Well, we had a pattern of adenocarcinoma. We can see that there is the napsin that is negative. And actually, this case went to a review in another anatomopathology laboratory because we have a diagnosis that is very difficult. And in a review of the exam with the surgeon, with the pathologist, everyone was discussing, they said, nope, it's an adenocarcinoma, primary of the lung. And at the time, they did a molecular analysis to define the primary site, and here are the notes of the pathologist. Here, justifying the pattern, the cribriform and papillary, the focal area of the lipid growth, and CK7 positive. They did an ALK mutation by immunohistochemistry. We have an ALK positive, D5F3, and here we can see that we did. Well, if you remember the first PET, and this is the second PET CT, basically 5 months spanning for the weight of the diagnosis. There was a long-term time. The PET had increased the pulmonary, we observed the increase of the pulmonary lesions and pleural thickening. Also the lymph node, we can see the cardiophrenic issues, and therefore the final diagnosis of this patient. When the patient got to us, already with the staging ready for treatment, it was an adenocarcinoma of the lung, PT3, CN2, with the pleural metastasis and original lymph nodes. We ended up doing the staging thereafter. There was the ALK positive with all the other driver mutations and a PDL1 of 30% by Ventana, PDL1 marker. So here, just increasing here the extension, 5 months of delay in the diagnosis. Remember, he is symptomatic. We can see the clear progression, specifically in the pleural. Up top is the first and the current study down at the bottom. Well, so the treatment we wanted to, this was published, alectinib was approved. We requested alectinib to start, but it was denied by the health insurance. Therefore, we ended up starting with crizotinib on the first line because of the healthcare plan said no in December of 19, and then the patient had a dysphagia that was very severe with crizotinib. I mean, he had a lot of difficulty swallowing. So that ended up taking the patient to the regular use, and he tells us that he used the medication because he traveled, he had to travel, so he was a little bit distant from treatment, and in 3 months, in the first CAT scan, there was an oligoprogression. We did the endoscopic upper digestive tract. There was no difference. And when he stopped the medication of crizotinib, then the dysphagia improved and he would eat again. Very intense, even for liquids, dysphagia. So he was not regular. He had an oligoprogression. He was oligosymptomatic. So we ended up insisting a little bit more because of the healthcare. But we tried to do a dose reduction with crizotinib, and we could do another 3 months, and then the CAT scan to the 3 months using every day. He managed to get a stable disease with a pleural nodes. And here, the CAT scan after crizotinib, a lesion that is apparently stable. And you can see the pleural. Here in August, the patient says, I can't stand this anymore. Dysphagia is killing me. So we ended up talking to the healthcare plan and we said, limiting toxicity, let's try alectinib. And then this time it was approved. We started 600 milligrams based in DM. And then the patient ended up having a severe myalgia. He had a CPK normal, but the myalgia was really intense. So we tried to keep the dose. We increased a little bit more the analgesia. First evaluation, he had a stable disease. It wasn't a brilliant response. It was not. And later we tried to descalinate the dose. And then the myalgia was very bad. So we reduced it to 300 milligrams even, Bezendium. And in the PET scan, we can see in the progression, and really we had a progression of the disease, the pulmonary and subpleural nodules. There was also a subcutaneous nodule here, very visible, that was bothersome. And also the progression of the disease in February this year. You can see on the left, the old PET, the progression of the disease. When we notice that there is more of a commitment in the lung. And here, once again, an increase of the pleural. And here in March, we ended up deciding to try the third line. It was discussed. Well, very poor response with the ALK. So we decided to get the decision, and the decision was to start lorlatinib. We started with the 100 milligram. With lorlatinib, he had a good tolerance, initial tolerance. It was actually the ALK drug that he tolerated the best. There was an increase in triglycerides, controlled with rosuvastatin. It was very well controlled. And he had a cognitive deficit. He said that he was, dizzier, but, nothing that really caused a problem to his quality of life. He wasn't dizzier, so he was aloof. And there was an increase in pain in the subcutaneous nodes. There was an improvement in the pain once we did the switch to lorlatinib, but in July we ended up repeating the PET, and there was really an increase in the lymph nodes, and mainly the subcutaneous lesion. Even though the pain had improved, the subcutaneous nodule at the thoracic wall had increased in size. So we ended up stopping with 4 months at lorlatinib. Here we can see a little bit of an increase, but the PET was very small in the 4 months. There was a lymph nodal commitment, so it was an oligopressure by PET, and since theoretically the subcutaneous nodule was bothersome, and because of the lack of response to ALK, we switched the treatment, and now we ended up doing the fourth line in lung. We are very evolved in this scenario, And we ended up doing cisplatin, pemetrexed, bevacizumab. We started in September. He came back last week, and I saw him for the third cycle. I just requested the exams. He's going to do it. But clinically speaking, we can see a good response in the nodules. There is a reduction, important reduction in moderate toxicity. A little bit more, nausea, mucositis, but very adjustable with medication. So 3 cycles thus far, and a good clinical response to the treatment. And now we're waiting for the first exams. Well, that's it. That's the clinical case. And now we're open for Dr. Todd Bauer and Eduardo Zucca for continue. So I'm going to start asking Dr. Todd Bauer, well, would you do anything, looking retrospectively at the case, would you do anything differently from what was done, what was presented by Dr. Raphael? And also in clinical practice, your clinical practice, Raphael lives very far away. He lives right in the frontier with Bolivia, here, Brazil and Bolivia, very far away region. No, and really, there is a lot of difficulty in access. And that's very important to take in, for a rebiopsy and, exams. The patient travels, in this case, 400 miles to go to the exam to get the PET scan. So there's a lot of difficulties. It's a big difficulty in the interior of Brazil. It's not a capital city. There is no PET scan in the city. There is no radiotherapy. So they have to, commute. So there isn't, precision medicine we have in the city because the laboratories exist. Yeah, and they submit. Okay, yeah. And now they actually submit these samples. Anyway, and would you do anything differently in this case, looking retrospectively? And besides the imaging exams, how would you also follow up this patient? Would you follow up by ctDNA? Would you, would you request any other exam, molecular exam, actually to help in the treatment? The floor is yours. Thank you.
For sure. Thanks. First, that's a great case. And a couple things in general. First, Raphael, I live in Tennessee, which everybody in New York and Los Angeles thinks is a frontier as well. So no worries about that. Second, I don't know if it's a misery loves company thing or not, but it's maybe a little bit comforting to me that you guys also have your care dictated by insurance companies to some extent, and it's insanely frustrating. So I feel your pain on that. Third, I've learned to never try and play Monday morning quarterback when I am not involved in the intimate care of the patient, because that's lots of discussions that I'm not privy to. In general, yes, I think that case was managed as well as it possibly could have been. Here's what we know about using lorlatinib after failing other prior ALK inhibitors. So one of the big cohorts in the phase 2/3 study for lorlatinib, which was parsed out into no prior ALK inhibitor, 1 prior ALK inhibitor, 2 or 3 or more than 3 ALK inhibitors. If you are able to test those patients, and I don't do this in my practice, I don't think this is standard of care even in the United States. If you are able to test them and look for a resistance mutation that has popped up within that ALK fusion. So the most common we think about is the G1202R resistance mutation that is so difficult for every drug but lorlatinib to treat. If you find a resistance mutation, the likelihood that the patient will respond to that is significantly greater than if you don't. What that predicts is that they've developed a bypass tract and the cancer is no longer dependent on just the ALK pathway to grow. So in the absence of doing molecular testing on every progression of every patient with ALK, the right thing is to try the next ALK inhibitor. If they don't respond, it's not because the drug doesn't work. It's because the patient's cancer has evolved not a resistance mutation to the ALK inhibitor they were on, but rather likely a bypass tract that they have developed around the ALK pathway. So I think that it was handled correctly. I am a little interested in the choice of cisplatin versus carboplatin in this patient. I'm maybe a little bit of a chicken, but I do like kidneys and I don't like dialysis. So is that more of a standard in Brazil to go with the cis versus the carbo in that situation?
Well, actually, no. Actually, it's more carbo than cis.
Okay.
But this patient, he has a neutropenia, like neutropenia degree 1, that ended up, worrying me a little bit more with the carboplatin, and he had a renal function that was normal, young patient, and I ended up, opting for cisplatin because of the light neutropenia and because of the high degree of myelosuppression that I could have with carbo. I didn't want to lose, and the chemotherapy, but usually we ended up using here in Brazil more carbo than cis, but that's also my day-to-day.
So this is why I try not to Monday morning quarterback, because there was a very good reason you did what you did, and I now sound a little bit foolish.
Well, now, Dr. Bauer, another question about my case. After we're using all the ALK medications. What is the role of immunotherapy in these patients? Would you use in this subsequent line the immunotherapy? Would you use, later after progression to the treatment with platin and pemetrexed, or do you not see the role for immunotherapy in these patients?
So I'm glad you asked that, and I think it's a great question. And I was really glad to see that your first line treatment after the ALK inhibitors was chemo plus Bev, not a immunotherapy. It does not seem in my clinical practice or in any of the data we have that immunotherapy plays a role in these molecularly driven cancers, most specifically in ALK-driven cancers. There's been some foray into ALK plus immuno, and it just does not seem to benefit the patients. So I don't think I've ever, outside of the bounds of a clinical trial, started a patient on immuno-oncologics who has an ALK fusion. It also brings up an interesting point about sequencing in the States. And this is, I'm going to be a little bit of the ugly American and apologize before I even say this. Nobody wants to wait the 2.5 to 3 weeks to start treatment for the broad-based profiling that we can get so readily, regardless of where we practice, even in the frontier of Tennessee. So the concern is that we know that exposing patients to the checkpoint inhibitors, there's a little bit of an increased risk in pneumonitis when you put them on a TKI after that. There was some EGFR data for that. So I worry about starting somebody on a chemo immunotherapy combination just because it's an easy thing to do, finding out a couple weeks or a month later that they've got a ALK fusion, and then starting that out TKI. I'm not going to not do it at that point, but if they were to develop a pneumonitis, boy, I'd sure be kicking myself because I could have avoided that had I just waited a few weeks until their profiling came back. So that to say, not only do I think it doesn't work, I think if you give a PD-1 prior to a TKI, can actually potentially increase risk of harm for the patient.
Perfect. Now, Dr. Todd, I also have a few questions, actually, in regards to metastases, brain metastases, yes, in patients with lung cancer. How would you see today, in regards the role of radiotherapy, even in patients that have a controlled disease, and even radiotherapy stereotactic for metastases localized, with a high rates of responses with lorlatinib and ALK inhibitors? And what is your experience when the patient has brain lesions? The medications, anticonvulsive, dexamethasone, they are very well used. And the medications, what is the role of these medications with the interaction, drug-drug interaction with lorlatinib? Should you, in practice, in the clinical practice, be careful with these medications?
So great questions and highly poignant based on the rate of primary presentation with CNS metastases. I'll tell you that this is one of the coolest things about our job, right? Is to be able to sit down with the patient, talk to them about the risks and benefits, and advise them and come to an agreement on what's the right treatment for that every individual patient. In a patient who has de novo presentation with CNS metastases, as long as they are asymptomatic and I think I can control any edema with steroids, I do not utilize radiotherapy in these patients up front with an outfusion if I'm putting them on lorlatinib, because I know how quickly and how well lorlatinib can work in the brain. Now, if they've got big midline shift and they're symptomatic or present with seizures, that's maybe a bit of a different discussion. The anticonvulsants and the steroids, there's no interaction with lorlatinib to my knowledge of the other ALK TKI, so I would use those readily. So up front, no, I don't think we need to utilize stereotactic radiosurgery for these patients, and certainly not whole brain radiotherapy. But let me go off on a tangent on that just a little bit. What if I have a patient who is one of the ones who doesn't respond in the brain to lorlatinib, one of those 3% who has progression in the brain at a year? If everything else is stable and we think about tumor heterogeneity, I absolutely will utilize stereotactic radiosurgery to zap 1 or 2 spots in the brain, maybe even an adrenal lesion that pops up, and try and knock it back down. Remember, I think about this as we want to provide the most quality benefit to our patients and quality of life and the greatest duration of benefit for our patients. I'm not going to throw away a good drug that I know I can get years of benefit out of because of the development of one lesion if I've got 95% of the disease controlled, right? I'll continue lorlatinib in that setting, treat a oligoprogressive disease with radiation, and repeat scans in 2 months. If they progress again, okay, I was wrong, let's shift them to another drug. But I think that you can significantly benefit the duration of therapy on these drugs by sort of what we call in the United States spot welding. I'm just going to zap this one lesion and everything else is going to continue to be controlled well. So 2 different scenarios for SRS in this patient population. No upfront, just use lorlatinib. If you need it down the road, it's a great mechanism to keep them on the drug longer.
Thank you very much, Dr. Todd. Now, we also have a question from the guys that are watching. So there's no question, there's no name, but the question is, well, facing the options approved for the cancer ALK positive, what are the criteria that you would use as a differential for the use of lorbrena in the first line in your clinical practice for NSCLC?
Sure. I think this is probably a multi-billion-dollar question if you were to ask our friends at Pfizer or any of the other producers of these drugs. If a patient has brain metastases, I would always use my best drug first. And I think based on our preclinical data, based on the CNS complete response rate, and based on the discontinuation rate of lorlatinib, I would use lorlatinib up front in a patient with CNS metastases. So that takes care of, let's call it 35% of the patients. What about the other 65%? Well, if I've got a patient who's a 35-year-old never smoker, who's an accountant, who thinks all the time and works all the time based on his brain, he's probably going to be reasonably well read on these things by the point he sees me. And this is a tangent. If you guys don't know this, the outpatient population is the most well-connected grassroots group of any patient advocacy group I've ever encountered. So he's going to know what the risks are to him. And I'm going to share with him that I think I can give him a better drug that's more protective against his brain or against cancer in his brain than anything else. So that is my bias because I think the brain is pretty valuable real estate. But if I have a patient who suffers from severe depression or they've had a history of psychiatric issues in the past, that comes into it as well. Again, this is the cool thing. We get to decide what is right for every individual patient in conjunction with that patient.
Excellent. Very good. Dr. Raphael, do you have any questions for Dr. Bauer? Yes, I do. If you'll allow me, I have another one. I want to get your opinion in regards to the patients with lung cancer, locally advanced, but not metastatic. Basically, the patients from, Pacific and, ALK mutated. Do you think that it's about time that we try to switch immunotherapy and start with an ALK radiotherapy, or no? No, we are still going to wait for the studies that are ongoing, and let's continue with our immunotherapy and radiotherapy.
I appreciate how you set that question up, because we've already established, how I feel about immunotherapy in this population. You already know how I feel about the payers in the worlds we both live in. I would love to be able to shift them and put them on what I believe is a better drug for them. I think we're going to have to wait on the studies to come out to confirm that before anybody's going to pay for it, unfortunately, which is mind blowing, right? That they'll pay in the States, it's $10,000 to $15,000 a dose for an immuno-oncologic versus that I don't think works very well, versus probably $10,000 to $12,000 for a month's worth of lorlatinib. So they're paying more for a less good drug with worse potential side effects down the road because they don't have the data. It's God bless our insurance companies.
Excellent. Well, Dr. Raphael, excellent. So, Dr. Bauer, we are getting close to the hour, 8 p.m. local time, 4 minutes. And I don't want to, hinder the rest of your evening, afternoon there in the United States. Therefore, I would like to thank you very much for your participation. I think that it was very fruitful. And I would like to thank Pfizer, our sponsor. Unfortunately, this is not live, but it's online and we can reach a lot of people. And this is very nice. Thank you very much I am very happy. I don't know if you want to comment here in the end. We have 3-4 years that we have clinical research and our Cancer Brazil Institute. We love clinical research. I used to do clinical research in my previous work. And when you started your talk, you said that you have a patient that has been treated for 7 years with lorlatinib because of clinical research. Most of the participants here that are online will work with clinical research also in our institute. Would you have any tips for those of us that are starting with clinical research, within, of course, here in Brazil? And thank you for your participation. Can you give us a little bit more of your thoughts?
Sure. Well, first, let me say thank you so much for inviting me to come join. It's a great honor. And I hope that whoever is watching this on webcast later on, or just recordings later on, I think the kids call it podcasting these days, I'm not sure, take something from this and is able to help take care of their patients a little bit better and at least learn from it. Clinical trials are hard, right? When I was in training, both in residency and in fellowship, the one answer that was never wrong for a patient with cancer was a clinical trial. Look, if we had the right answer to treat cancer and make it better, we wouldn't need clinical trials anymore. And what a wonderful world that would be. Where we are now, we make incremental growth, right? You take a disease, let's look at non-small cell lung cancer. I can remember a time in fellowship when the first ALK study came out and somebody's like, wow, isn't that incredible? We could think about talking about lung cancer like we talk about lymphoma, a treatable disease. And here we are, okay, a decade later, I'm getting older, where we see that transition, that ALK positive lung cancer, we may not cure it, but we can treat it, and we can treat it for years and years. We now have these different therapies to stack it. So as you look at the challenges that go along with clinical trials, and they are administrative, and they are logistical, and they are financial, it's always worth it to think about a clinical trial for your patient, putting their interest first and foremost, but knowing that the residual benefit helps every single cancer patient who will come after them. So keep fighting the fight, guys. We do the same every day up here north of the border.
Perfect. Thank you very much. Thank you very much to everyone that is following up. Thank you, Professor Bauer. Thank you, Professor. Thank you, everyone, for your presence.
Thank you, everybody.